Okay, so we're going to begin a series of lectures on cardiac radiology, and this is a series of lectures that is directed at radiology residents. So the goals for this series of lectures is to help you to pass the cardiac section of the radiology board exam, also to do well on the cardiac portion of the in-training exam, to become familiar with the basics of cardiac imaging, and to develop a foundation to advance your knowledge after residency should you choose to do cardiac imaging in your practice. So our first talk here will be on basic anatomy and physiology, and it is important to be able to differentiate the morphologic atria from the anatomic atrium, especially when you're dealing with complex congenital heart disease. It's not always the case that the atrium on the right side is the morphologic right atrium. So we'll start with this question: which of the following is most reliable for identification of the morphologic right atrium? And it turns out that the answer is it is the chamber that receives the inferior vena cava. Now we know that the superior vena cava usually drains into the right atrium, but you can have a rare anomaly, a left superior vena cava associated with an unroofed coronary sinus, and if you have that association, then the left superior vena cava can actually drain into the left atrium. The tricuspid atrioventricular valve, the atrioventricular valves stay with the ventricles, so the tricuspid atrioventricular valve is a property of the morphologic right ventricle. The chamber with the tubular appendage and a narrow neck, that of course is referring to the left atrium. That is the morphology of a left atrium, not the right atrium. So there is a difference between the anatomic and the morphologic atrium, and the same is true of the ventricles. So this is a case of a dextral version, as it turns out, and we'll get into these more complicated cases later on in this course. But when you're dealing with complicated cases like this, where the position of the heart itself becomes puzzling, in order to figure things out, you need to be able to differentiate the morphologic atria and the morphologic ventricles, and then to determine their connections. So the right atrial appendage is somewhat triangular in configuration and has a wide ostium. Contrast that with the left atrial appendage, which is tubular and has a more narrow configuration, and the ostium of the left atrial appendage is also narrow. This is why in patients with atrial fibrillation, the left atrial appendage is a common location to develop blood clots. You get stasis of flow in that region here because of that narrow opening, and so blood clots can form there within the left atrial appendage. The right atrium usually receives blood from the superior vena cava, inferior vena cava, and coronary sinus. The best way to identify it on imaging studies is to identify the chamber that receives the inferior vena cava. There is no congenital heart disease where the inferior vena cava drains to a morphologic left atrium. The fossa ovalis, marking the site of a closed foramen ovale, that is also found within the right atrium. And the foramen ovale does remain patent in about 25% of cases, and we'll discuss the significance of that later. Now, the right atrial appendage may contain these linear filling defects. This is normal. These are called the pectinate muscles. We don't want to mistake that for any kind of pathology. Also, the eustachian valve, which is the valve of the inferior vena cava, as the inferior vena cava empties into the right atrium. Here's an example where it is unusually prominent, and we don't want to mistake that either for pathology. The conduction system, the AV node, is also found within the right atrium, but that is not something that we will be able to determine on imaging. So let us discuss this case. Echocardiography shows an intracardiac mass, and you can see here on CT this mass here is located within the right atrium, and here it is on MRI. We can see this mass along the wall of the right atrium. So the question is, what is it? And it's important to be able to identify this as a normal structure. This is the crista terminalis that is normally found within the right atrium. That is a muscular ridge that separates the trabeculated right atrial appendage from the smooth-walled portion of the right atrium. This occurs from incorporation of the sinus venosus into the right atrium during embryology. This also contains nerve fibers that connects the SA node to the AV node. So Here you can see that ridge that extends from the line connecting the superior vena cava to the inferior vena cava, and that separates the smooth-walled portion of the right atrium from the more trabeculated portion of the right atrium. The asterisk here is marking the foramen ovale. Now here we have another CT image, and I'm asking you, what is this tubular structure that is found here along the inferior margin of the heart? And that, of course, is the coronary sinus that receives the coronary veins and that drains into the right atrium. On this particular image, this is the right atrium, here's the right ventricle, here's the left ventricle, here's the interventricular septum, and here running in the right atrioventricular groove, that of course is the right coronary artery. Here we have two different structures, and the question is, what is each? So here we have a sagittal view here going through the right atrium. This is the superior vena cava. This is the inferior vena cava emptying into the right atrium. What is this ridge of tissue? And that, of course, is the valve of the inferior vena cava. That is the Eustachian valve. And here we have the coronary sinus also emptying into the right atrium. What is this linear filling defect that we see here? That, of course, is another valve, and that is the Thebesian valve. That is the valve for the coronary sinus. So the Eustachian valve is the valve for the inferior vena cava, the Thebesian valve, the valve for the coronary sinus. And so here on this diagram, we have the Eustachian valve here, the valve for the inferior vena cava, the Thebesian valve, the valve for the coronary sinus. Now moving on to the left atrium usually receives the four pulmonary veins in the posterior wall. The left atrial appendage, that's morphologically the best way to identify the left atrium here. So we talked about the tubular shape of that and the narrow opening, the narrow ostium, as it empties into the left atrium. So here on this axial image, we can see the left atrial appendage. Here's the ostium of the left atrial appendage. Here on this two-chambered view, here's the left atrium and the left ventricle. So here is the left atrial appendage here, and here is the narrow ostium of the left atrial appendage. Here again, a two-chambered view showing you the left atrium, left ventricle. Mitral valve is in here. Here is the left atrial appendage. There is the ostium. And on this volume rendered view, showing you here again that tubular configuration of the left atrial appendage with the narrow ostium where it empties into the remainder of the left atrium. Series of axial views here showing you the left atrial appendage here, here, and on this view we can see the ostium, and then here is our two-chambered view again showing you the left atrial appendage and the left ventricle. And then here again on this volume rendered view, here we can see that triangular shape of the right atrial appendage, and then as we come around, here's the right coronary artery, here is the right ventricular outflow tract going into pulmonary artery, and then as we come around here to the left side, we get to the left ventricle here, and then here is our left atrial appendage, that tubular configuration. Okay, now the left atrial appendage is anterior to the left superior pulmonary vein. So here is the left superior pulmonary vein as we follow that down in our series of axial views. And then here is the left atrial appendage, just anterior to the left superior pulmonary vein. And then here we will get into the ostium of the left atrial appendage into the remainder of the left atrium. So what about this question? Where is the Coumadin ridge? Where is that located? That, of course, is also located within the left atrium. So the Coumadin ridge represents this infolding of tissue here. This is also called the Q-tip sign. Looks like a Q-tip here at the tip. So it's infolding of the left atrial wall at the junction with the left inferior pulmonary vein here. So this is also called the Coumadin ridge, as it can be mistaken for thrombus on echocardiography. And the ligament of Marshall. So this area here is also the ligament of Marshall, and that's a remnant of the vein of Marshall, which obliterates during embryology, leaving us that ligament of Marshall. All right, so let's discuss, let's take a look at these images and discuss this case for a second. What do we think of this case? So here we have a large saddle pulmonary embolism, And when we look down in the abdomen, we notice that there is this triangular appearing area of low attenuation here within the kidney. That, of course, represents an infarct. And then when we look here, the more inferior aspect of the abdominal aorta, we see a filling defect. So there's a clot here within the abdominal aorta. So this patient has clot on the right side of the circulation, and there's evidence of clot on the left side of the circulation, resulting in an infarct here in the left kidney. So this represents paradoxical embolism. So when we see paradoxical embolism, when we see evidence of clot on both sides of the circulation, we need to think of a communication between both sides of the circulation, and the most common of those would be a patent foramen ovale. So somebody who's having pulmonary embolism, if they have a patent foramen ovale, they're a perfect setup for paradoxical embolism, because what happens is they will already have clots that are traveling through the right side of the heart as a result of their pulmonary embolism, and they can have elevation here in the pressures on the right side of the heart as a result of obstruction of the pulmonary artery from clots, and that can force right to left shunting across the foramen ovale. The clots get across, and then resulting in clots on the left side of the circulation, or paradoxical embolism. So here, what is the arrow pointing to here? Well, here we have the right atrium, here we have the left atrium. This patient has some prominent interatrial fat here. So this is some lipomatous hypertrophy of the interatrial septum, but that brings out this region in here. So that is the foramen ovale. So that is not an atrial septal defect. This indentation in here represents the foramen ovale. So we don't want to mistake the fossa ovalis, which is the remnant of the foramen ovale, the closed foramen ovale. We don't want to mistake the fossa ovalis here for an atrial septal defect. Okay. Now the atrial septum itself can have somewhat of this complicated appearance as a result of the embryology and the formation of the patent foramen ovale. So basically, what you have here is a flap-like mechanism going across the interatrial septum, and this patent foramen ovale, what that does is it allows right to left shunting in utero to bypass the non-functioning lungs for the fetus, and then after the baby is born, what happens then is the pressures on the left side of the heart increase, and when that occurs, then the pressures on the right side decrease as you get air perfusing the lungs. And then what happens is that the difference in pressures between the left and the right causes this flap to close, and then eventually that seals, completely closing the foramen ovale. However, in about 25% of cases, this can remain open, potentially allowing communication through here, allowing the formation of paradoxical embolism. So the significance of a patent foramen ovale is that it can be associated with paradoxical embolism. Can we make the diagnosis of a patent foramen ovale with MR? It turns out that yes, you can. Can you make the diagnosis of patent foramen ovale by CT? Of course, you can do that too. The best way, the most accurate way to make that diagnosis, though, of patent foramen ovale is with transesophageal echocardiography, especially with a bubble study to identify the patent foramen ovale, or to identify the foramen ovale and its patency. So in about 25% of cases, it can remain patent, and that is a setup for paradoxical embolism, especially if there is pulmonary embolism, as in this case here. And you can see saddle pulmonary embolism, and then there's some clots extending down into the common iliac arteries, clots on both sides of the circulation, implying communication between the right and left circulations. So we said that on MR, it is possible to make the diagnosis of a patent foramen ovale. So we can do this with a dynamic study as we are injecting contrast. So as we are injecting contrast, we continuously image the heart, and then we ask the patient to bear down, to force some of that contrast to go across the atrial septum, and then the diagnosis is made when we have that early appearance of contrast within the left atrium. You can see the arrow points to that little flash of contrast within the left atrium before the contrast actually appears within the pulmonary veins. So contrast should get to the left atrium through the pulmonary veins, but if you have a patent foramen ovale, then we will see this early appearance of contrast in the left atrium before it has actually arrived in the pulmonary veins. So here's another example with MR. So we have a 4-chamber view here. We see the contrast going into the right atrium and the right ventricle as we inject it. Then we ask the patient to bear down, and then you saw that there's a little flash of contrast going across the atrial septum into the left atrium right there, and that's a result of a patent foramen ovale. So we see that before we actually see the contrast arrive within the pulmonary veins. Now the CT criteria for a diagnosis of patent foramen ovale. So we want to see a flap in the left atrial in the left atrium at the expected location of the septum primum, a continuous column of contrast material between the septum primum and the septum secundum connecting the left and right atria, and a jet of contrast material from the column into the right atrium. So here's a short axis view. Here's the left atrium, here's the right atrium. So here you can see that flap-like mechanism here of the patent foramen ovale, and you see that little jet of contrast going across there between the left atrium and the right atrium. So that indicates that we are dealing with a patent foramen ovale. So we see the flap here in the left atrium. We see that column of contrast within the flap going across from the left atrium to the right atrium. Now, is there anything about this that might bother you? Well, we just said that theoretically a patent foramen ovale should allow flow from the right atrium to the left atrium. It's a flap-like mechanism, but it should close and not allow flow from the left to the right side. Although it's because of that flow from the left to the right side that we're able to identify it here on CT. So it turns out that like all valves in the body, this valve can be incompetent. So in reality, it allows a little bit of bidirectional flow, although that itself is not physiologically significant, that bidirectional flow through here. What is significant is the association with paradoxical embolism, because just small clots on the left side of this circulation can be devastating if they lead to strokes. So on CT, the patent foramen ovale here on this 4-chambered view, left atrium, left ventricle there, right atrium, right ventricle. So we can see here that the foramen ovale, the patent foramen ovale, looks like a tunnel. And then here, very nicely demonstrated on this 2-chamber, on this short axis view. So here is the left atrium here, and here is the right atrium on this short axis view. And you can see that tunnel going across the interatrial septum with the flap-like mechanism. That's how we can identify a patent foramen ovale on CT. Now, an atrial septal defect is a hole. So an atrial septal defect is a hole in the atrial septum. A patent foramen ovale is this tunnel going through the atrial septum with this flap-like mechanism there on the left atrial side. So that's how to differentiate a patent foramen ovale from an atrial septal defect. Now, the atrial septal defects, since we touched on those, are also named based on their location. Their location here within the atrial septum, so a defect close to the insertion of the superior vena cava or inferior vena cava is the sinus venosus atrial septal defect. The secundum atrial septal defect occurs right in the middle of the interatrial septum. That is the most common type. And the ostium primum atrial septal defect that occurs along the inferior margin near the junction with the ventricles. So that is associated with endocardial cushion defects. Now let's move on to the ventricles. Which of the following is most reliable for identification of the morphologic right ventricle? Well, we know that usually the morphologic right ventricle connects to the morphologic right atrium, right? The right atrium connects to the right ventricle. However, you can have Congenital heart disease, like congenitally corrected transposition, where you have atrioventricular discordance. In that case, then the morphologic right atrium does not connect to the morphologic right ventricle. It connects to the morphologic left ventricle. Connection to the pulmonary artery, we know that usually the morphologic right ventricle connects to the pulmonary artery, but you can have congenital heart disease like transposition, and transposition is best understood as ventricular arterial discordance, and in that condition then the morphologic right ventricle connects to the aorta and the morphologic left ventricle connects to the pulmonary artery. Prominent trabeculations of the ventricular wall. In most cases, the right ventricle is more trabeculated than the left ventricle, but you can have a condition like non-compaction of the left ventricle, where the left ventricle becomes abnormally trabeculated and can be even more trabeculated than the right ventricle. So the best way to identify the morphologic right ventricle is the muscular infundibulum that separates the inflow from the outflow valve. So we need to discuss the anatomic, the differences between a morphologic right ventricle and a morphologic left ventricle. So the morphologic right ventricle, the inflow valve is a 3-leaflet valve. It's a tricuspid valve. But the key difference that we can identify in imaging is the outflow, or the infundibulum here, the outflow tract of the right ventricle. So the infundibulum is this myocardium that separates the inflow valve from the outflow valve. So there's separation between the inflow valve and the outflow valve of the right ventricle by the outflow tract, which we call the infundibulum. Now the left ventricle, the inflow valve and the outflow valve share a fibrous skeleton. So the anterior leaflet of the mitral valve actually takes you to the aortic valve. This is called fibrous continuity. So notice that the anatomic relationship here between the inflow valve and the outflow valve for the morphologic left ventricle, they are very close together because they share the same fibrous skeleton here. So they're not separated like we have with the morphologic right ventricle. So here is a left ventricular outflow tract view. This is the left atrium. This is the left ventricle. So here we have the mitral valve that separates the left atrium from the left ventricle. This is the aortic valve. And so this represents the anterior leaflet of the mitral valve. So you follow that anterior leaflet and it takes you right to the aortic valve. So, as we've said, there's fibrous continuity between the anterior leaflet of the mitral valve that takes you to the aortic valve. And in most cases, the papillary muscles here of the morphologic left ventricle are better defined than that of the right ventricle. However, as we've said, the best way to differentiate the morphologic right ventricle and the left ventricle is the infundibulum for the right ventricle and fibrous continuity of the inflow and the outflow valves for the morphologic left ventricle. So for the morphologic right ventricle, we look for separation between the inflow and the outflow valve. There's this outflow tract here composed of myocardium that separates the inflow and the outflow of the morphologic right ventricle. So here we can see it on this view. So here's the right atrium. The tricuspid valve would be in here. This is the inflow going into the right ventricle. Here is the outflow. There's the pulmonic valve. Notice that wide separation between the inflow valve and the outflow valve. So that is what we see with a morphologic right ventricle. So for morphologic right ventricle, separation between the inflow valve and the outflow valve, and the outflow tract of the right ventricle is called the infundibulum. And then here on the volume rendered views, you can see that muscular outflow tract of the right ventricle is the infundibulum separating the inflow valve from the outflow. Okay, now this is another feature that is associated with the morphologic right ventricle, and this is called the moderator band. So the moderator band is this trabeculation that connects the interventricular septum to the anterior free wall of the ventricle. This is also a feature of a morphologic right ventricle. If you're asked to choose between the moderator band and the infundibulum, pick the infundibulum, but the moderator band is also a feature of the morphologic right ventricle. There are papillary muscles also within the right ventricle, although these are usually not as well defined as the papillary muscles of the left ventricle. Now, the septal leaflet of the tricuspid valve of the right ventricle is also displaced slightly towards the apex relative to the septal leaflet of the bicuspid valve for the left ventricle. So you can see that there's this little region right in here called the atrioventricular septum, and that region then separates the right atrium from the left ventricle. If this leaflet is displaced too far towards the apex, then we have a congenital heart disease called Epstein's anomaly. So as we said, if you follow the anterior leaflet of the mitral valve and we go upwards, that will take you right to the aortic valve. So that's an example. That is fibrous continuity. That is the feature of a morphologic left ventricle. Very nicely demonstrated on the three-chamber view. Left atrium, left ventricle, anterior leaflet of the mitral valve takes you right to the aortic valve, fibrous continuity. Now the left ventricle also has two well-formed papillary muscles. Here on this short axis view, here's the left ventricle, here's the right ventricle. We have these two well-formed papillary muscles. We have the anterolateral papillary muscle there with the yellow arrow and the posteromedial papillary muscle there with the green arrow. So which one is more likely to rupture if there's a myocardial infarction? And it turns out that it is the posteromedial papillary muscle that is more likely to rupture, because the anterolateral papillary muscle has a dual blood supply. It can be supplied by the left anterior descending artery or the left circumflex coronary artery, whereas the posteromedial papillary muscle here is supplied by the distal right coronary artery. So rupture of this muscle, the posteromedial papillary muscle, in association with myocardial infarction is more common than rupture of the anterolateral papillary muscle. And so these are some CT images illustrating the papillary muscles. These are normal findings, so we don't want to mistake these for clots or filling defects within the left ventricle. So when we compare the morphologic left ventricle with the right ventricle, for the left ventricle, fibrous continuity. The anterior leaflet of the mitral valve takes you right to the aortic valve. For the right ventricle, we have separation of the inflow and the outflow valves here, and because of the infundibulum, the outflow tract there of the right ventricle. Now, which cusp of the aortic valve is this? So this cusp is closest here to the anterior leaflet of the mitral valve. That is the posterior or non-coronary cusp. So which cusp of the aortic valve is this? Well, in this case, you can actually see the right coronary artery coming off here. So this would be the right cusp of the aortic valve. This would be the left cusp. Here's the left main coronary artery. And then this would be the non-coronary or posterior cusp. The landmark for the posterior or non-coronary cusp is the interatrial septum. So here's the left atrium, here's the right atrium, a little bit of the superior vena cava here at the junction of the SVC and right atrium. So the interatrial septum is the landmark for the posterior or the non-coronary cusp. So you identify that, try to identify that first, especially if you can't see the coronary arteries on your image. And then you can once you've identified the posterior non-coronary cusp, then you can go on to identify the right and left coronary cusps. Okay, so now looking from the top down on this volume rendered view, here's the non-coronary cusp, here's the interatrial septum, here's the right cusp, here's the right coronary artery, left cusp, there's the left main coronary artery there. So as we're looking down now in this drawing from the top down, okay, so then this would be the right side, this would be the left side as we're looking from the top down. So we have the left cusp here, the right cusp here, and then the posterior or the non-coronary cusp back there. Now for the pulmonic valve, so the pulmonic valve has an anterior cusp and it also has a right and a left cusp. Again, we're looking from the top down here on this drawing, anterior, right, and left. Those are the cusps of the pulmonic valve. Now, what is the normal relationship of the pulmonic valve relative to the aortic valve? This is something that you should not even have to think about, and the answer is the pulmonic valve is anterior, superior, and to the left of the aortic valve. So the pulmonic valve is anterior, superior, and to the left. The aortic valve is buried down in there to the left of the aortic valve. So the pulmonary artery actually kind of spirals around the ascending aorta. As you can see there on this volume rendered view, is the pulmonary artery coming up and sort of spiraling around the ascending aorta. So is this an aortic dissection? And the answer is no. This is just motion artifact. This is a non-gated study. So that's motion artifact there at the aortic root. So it's a pseudo dissection for motion at the aortic root. If this becomes a real consideration, you can bring the patient back for a gated study if you need to differentiate motion artifact from a real dissection. Is this an aneurysm of the aortic root or the sinus of Valsalva? And again, the answer here is no. So this occurs because in the axial plane, we tend to over-measure the diameter of the aorta, especially near the aortic root. So on an axial image, you'd be taking an image like so, and that's not actually within the plane of the vessel itself. So for your most accurate measurements of the aorta, especially at the aortic root and the ascending aorta, you want to take a plane that is perpendicular to the actual course of the vessel. So you start with your coronal view, and then if you're looking here at the sinuses of Valsalva, you take a reformatted view through there, and that gives you a very nice view here of the actual diameter of this aorta. Same thing is true of the ascending aorta. So your best measurement for the diameter of the ascending aorta you can get from your coronal views. Same thing is true of the pulmonary artery. You can easily over-measure the pulmonary artery because on axial images you're not truly within the plane of the course of the vessel. So that's not a true aneurysm. It's kind of a pseudo-aneurysm of the pulmonary artery. For the coronary arteries, we will get into the discussion of detailed discussion of the anatomy of the coronary arteries later on within this course. And then we'll discuss how we generate images like this on CT and the actual anatomy and the pathologies that we need to be familiar with when we're dealing with the coronary arteries. Now, some few brief words about cardiac physiology. So the cardiac output formula, cardiac output is determined by the heart rate times the stroke volume. The stroke volume is determined by the afterload. And afterload is resistance of the ventricle. The resistance of the ventricle works against during systole. And also the preload, that is the volume the ventricle receives before systole. And the contractility, it's the force with which the myocardium contracts. So these are the three determinants of stroke volume. Now we can divide categories of heart disease depending on which of these are affected. So abnormal afterload, these are pressure overload lesions. So for the left ventricle, this can occur with aortic valve stenosis, with coarctation, with systemic hypertension. For the right ventricle, this can occur with pulmonic stenosis, with pulmonary arterial hypertension, and with mitral stenosis, as the pressures of mitral stenosis result in pulmonary venous hypertension, which then backs up into the pulmonary arterial circulation. So latent mitral stenosis patients can develop pulmonary arterial hypertension, which then becomes a pressure overload lesion for the right ventricle. Abnormal preload diseases, these are volume overload diseases, so the overcirculation, left to right shunts, valvular regurgitation, aortic regurgitation, mitral regurgitation, tricuspid regurgitation. So these can give you abnormal preload or volume overload lesions. Decreased quantity of myocardial contractile units. We can see this with myocardial ischemia and infarction. Decreased quality of myocardial contractile units. We can see this with cardiomyopathies or myocarditis. So mechanisms of cardiac compensation If there's increased afterload, the mechanism, and there's pressure overload, we get hypertrophy of chambers, thickening of walls. The size of the chamber remains normal. We can't see left ventricular hypertrophy on a chest radiograph. We can't have increase in the filling pressures because of decreased compliance as a result of the hypertrophy. Abnormal preload, we get volume overload. Here we do get dilatation of chambers. We get some hypertrophy, but not as much as with pressure overload. The size of the chamber does increase, and our mechanisms of compensation will try to maintain the cardiac output until ventricular failure occurs. And we know that left ventricular failure results in pulmonary venous hypertension and pulmonary edema. So let's move on to the radiographic views and what we need to know as far as enlargement of chambers. These are some basic radiographic views: PA, lateral, right anterior, and left anterior oblique view. So on the frontal view, the right border of the mediastinum is superior vena cava, and then we have the right atrium, and then down here we have the inferior vena cava. For the left border, we have the aortic arch or the aortic knob, main pulmonary artery, below that left atrial appendage, and then below that is the left ventricle. So here, superimposed on the chest radiograph, the right border of the mediastinum, superior vena cava, right atrium. The left border, we have the aortic knob, main pulmonary artery, left atrial appendage, and then the rest of the left heart border is made up by the left ventricle. So on this chest x-ray, we have superior vena cava here, and then the right atrium here. On the left side, we have these three moguls, or these three bumps, roughly about the same size. The first is the aortic knob, second is the main pulmonary artery, and the third is the left atrial appendage. Right below that, you have the left ventricle. Another nice way to identify the left atrial appendage, you look for the airway, the left main bronchus, and where that ends, right below that, that is the region of the left atrial appendage on your chest radiograph. So there's a nice close-up, again demonstrating that the aortic knob, main pulmonary artery, left atrial appendage, left ventricle, where the airway ends here, right below that is the region of the left atrial appendage. On the lateral view, the anterior border of the heart is mostly made up of right ventricle and pulmonary outflow tract. The posterior border, the upper border is the left atrium, the lower border is the left ventricle. So on the lateral view, most of this anterior border here will be the right ventricle going into pulmonary outflow tract. The posterior border, the upper border is left atrium, and the lower border here is the left ventricle. This is the pleural reflection here over the inferior vena cava, so we can also identify that on the lateral view. Now, these oblique views, these are used especially in nuclear medicine for separating the atria and the ventricles. The right anterior oblique view separates the atria from the ventricles, so you can see here that the right atrium, it separates here the right atrium from the right ventricle. So that's good for the anterior oblique view. Again, it's used in nuclear medicine, separates the right atrium here from the ventricle. The left anterior oblique view, this is good for looking down the septum, the interventricular septum, and separating the right ventricle from the left ventricle. So left anterior oblique view separates the ventricles from each other. And again, that's also used in nuclear medicine, right ventricle, left ventricle. Here's your left anterior oblique view separating the two. Now, we're getting to the cardiac valve. So which valve is this? Well, this ring turns out to be in the location of the mitral valve. Here we also have the aortic valve here, also demarcated. So how do we determine the location of the cardiac valves? So on the lateral view, it's easiest to do on the lateral view. You draw a line from the bifurcation of the airway to the anterior cardiophrenic angle. Then we look right in the middle of the heart. Just anterior to that line is the aortic valve. Just posterior to that line is the mitral valve. The pulmonic valve is the most superior valve. The tricuspid valve is the most inferior valve. So notice the proximity of the aortic valve and the mitral valve because of fibrous continuity. Notice the separation of the tricuspid valve and the pulmonic valve because of the infundibulum. On the frontal view, it's a little bit harder to differentiate the aortic valve from the mitral valve. The pulmonic valve is still the most superior valve. The tricuspid valve is the most right-sided valve and the most inferior valve. So as we said, the pulmonic valve would be anterior superior and to the left of the aortic valve. Now, when we're dealing with cardiac chambers, if I ask you which chamber is enlarged here, we see this big opacity here, so that represents the right atrium. So that's enlargement of the right atrium. So with right atrial enlargement, it enlarges to the right, and posteriorly you see this big bulge along the right heart border, elongation of the right heart border. The length of the right heart border looks too long. You might also have dilatation of the inferior vena cava because of elevated pressures within the right atrium. So here's a CT correlating with that. Here you can see your dilated right atrium. In that particular case, this patient also has a dilated inferior vena cava. Now, here we can see a dilated inferior vena cava, dilated pulmonary artery. This patient also has a big right atrium. So this patient has a combination of pulmonic stenosis leading to poststenotic dilatation of the pulmonary artery and tricuspid regurg resulting in a big right atrium and a dilated inferior vena cava. What underlying condition could cause both of these, pulmonic stenosis and tricuspid regurg? And the answer is carcinoid heart disease. And again, we will discuss that in more detail later on in the course. Now, what about this radiograph? Which chamber is enlarged here? Well, right off the bat here, we can see that there is enlargement of the main pulmonary artery here. When we look behind the right atrium, there is this double density. There is also some straightening here of the left heart border. So all of this points to enlargement of the left atrium. The double density is the best sign there on the frontal radiograph for enlargement of the left atrium. This is a patient with mitral valve stenosis. So the double density behind the right atrium represents enlargement of the left atrium. Now, widening of the subcarinal angle, that's a very subtle finding. It's a difficult finding to make on the chest radiograph. Enlargement of the left atrial appendage, that is something that you will be able to identify on the chest radiograph. So below the main pulmonary artery here, which is enlarged, there's also some displacement here of the left atrial appendage away. So there is some enlargement there of the left atrial appendage. Now, the earliest sign on the radiograph is posterior and superior displacement of the left lower lobe bronchus, as illustrated here. So if you're asked about that on an exam, that is the earliest sign on the radiograph of left atrial enlargement, posterior and superior displacement of the left lower lobe bronchus. Also, the esophagus might be deviated posterior and to the right. Now, what about this case? What chamber is enlarged here? Well, here we have this elevated apex, somewhat of a boot-shaped heart, a child with a history of tetralogy of Fallot. So this is right ventricular enlargement. So when we're talking about ventricular enlargement, when there's enlargement of the right ventricle, the apex goes up. When there's enlargement of the left ventricle, the apex goes down and out. So down and out for enlargement of the left ventricle, up for enlargement of the right ventricle. So with right ventricular enlargement, we will have an upturned apex on the frontal view. And on the lateral view, the right ventricle may encroach on the retrosternal clear space, and the right ventricle may look too tall on the lateral view. So the boot-shaped heart, your typical configuration of tetralogy of Fallot. This is a patient with big main pulmonary artery, some enlargement of central pulmonary arteries. This is a patient with pulmonary hypertension. Also has enlargement of the right ventricle. Notice the heart looks too tall here. There's encroachment on the retrosternal clear space because of right ventricular enlargement in this patient with pulmonary hypertension. Here we have the apex going downward and extending laterally. So this patient has enlargement of the left ventricle. So remember, with left ventricular enlargement, the apex goes down and out. Another example, the apex going down here and laterally in a patient with left ventricular enlargement. Now, there is something called the Hoffman-Riegler sign for identifying left ventricular enlargement on the lateral radiograph. So we look at the posterior border of the heart. 2 centimeters above the diaphragm if that posterior border is greater than 1.8 centimeters posterior to the IVC shadow. In this case, it measures 2.3 centimeters. Then that indicates left ventricular enlargement. So this is not reliable if there's a rotated view, if there's right ventricular enlargement, or if there's a pectus deformity. Again, this is kind of a maybe just historical significance, but the Hoffman-Riegler sign on the plate film is also a sign of left ventricular enlargement. When there's dilatation of the left atrium, notice that when we put barium in the esophagus, we have this bulge along the upper posterior border of the heart. Here's a patient who has dilatation of the left atrium and the left ventricle. Notice now there's this bulge in the upper portion of the heart from left atrial enlargement, and there's the bulge in the posterior portion from the left ventricular enlargement. So enlarged left ventricle, the apex goes down and out. And then this patient happened to have a positive Hoffman-Riegler sign, and then that left ventricular enlargement is also confirmed here on this non-contrast CT scan. We can see that the left ventricle is pretty big. Okay. Now, the anatomy that I've pointed out during this lecture, we can also identify this even on non-cardiac gated scans. Even on non-cardiac gated scans, you can identify the chambers, the left atrium. You can identify sometimes the main coronary artery here, left atrium, left ventricle, right atrium, right ventricle. In this case, we can also identify the coronary sinus here, the interventricular septum. So much of this anatomy you can also determine even on non-cardiac gated scans. Here's a nice 4-chamber view on this non-gated scan: left atrium, left ventricle, right atrium, right ventricle. Here we have the mitral valve, here we have the tricuspid valve, and then right here we talked about this atrioventricular septum that separates the left ventricle from the right atrium. It turns out there is a congenital heart disease where you can have a defect right there within that atrioventricular septum, and you get direct communication of the left ventricle to the right atrium with a left to right shunt. That is called a Gerbeaud defect, a very rare congenital malformation where you have a hole right there within the atrioventricular septum, allowing direct communication of the left ventricle with the right atrium. Okay, well, that concludes this portion of our lecture, and I thank you for your attention.